So at the beginning of last year, we decided to change our program and treat the whole hemithorax in patients who were suitable. And this was the first patient we treated back in January 2009. He'd had a pleurectomy decortication, he'd progressed, he'd had 6 cycles of chemotherapy, and this was his subsequent PET scan showing activity involving mediastinal nodes, the area around the diaphragm, and the fissures between the lobes of the lung. And we gave that 50 to 60 Gray, and 3 months later this is the PET scan showing all these hot spots have progressed. The activity on the PET scan didn't go down very much, and that may have been due to some radiation pneumonitis. He did have a cough and trouble breathing, which we needed to put him on steroids, but unfortunately he then developed metastases in this lung, so that confused our analysis. And he survived 16 months after his radiotherapy. So we've had other patients who've had long-term benefits. This was one man who was 37, had a pneumonectomy, and back in 2007 we didn't have our program ready to start, so I said he should have chemotherapy while he was waiting. When we did our PET scan to plan his treatment, he'd already had a relapse in this area here. So we included that to a higher dose and treated the rest of the hemithorax to 50 Gray, and here's the PET changes. He's still alive 3.5 years later, and there's been a 92% reduction in activity in this small area. This is a longer follow-up of a patient treated back in 2005 who had a similar course of radiotherapy to the first patient, and you can follow the reduction in levels of TGVs up to 5 years later. At this point we did another PET scan which showed that although he had no recurrence in the original area, there was a hot spot up here. And because he hadn't had chemotherapy originally, we gave him chemotherapy at this point, followed by a second course of 50 Gray radiotherapy to the top part of the lung, and he's survived another 12 months. He's very well, has no symptoms, despite the fact that when we originally treated him, he did have some necrosis of a part of the liver using the old technique, and for a month or two he developed a lot of abdominal pain, fevers, nausea and vomiting, which resolved, and now his has normal liver and other function after that. So the next problem that we had to face was what side effects we were doing and what organs we were giving high doses to that may cause major toxicity. It's been reported in other series. And this is our data for acute toxicity in 35 patients who we've been treating, and you can see that we've had no grade 4 or 5 toxicities, and most of the patients get through the 6-week course with mild weight loss, some fatigue, nausea and vomiting. We take good care now to make sure they don't get too dehydrated, and we supplement their food intake. We used to boost the scars in the initial part of the series, but we don't do that anymore, so we've reduced the risk of radiation dermatitis. There have been very few hematological tests showing abnormalities, and the few who have had liver function abnormalities have all resolved. We've had no long-term toxicities. We're treating patients who now have the whole lung intact, not as most other centres do, only after pneumonectomies. And we've disproven the fact that radiotherapy to this area using the doses we go to can be very dangerous and often fatal. And that was introduced originally by a paper from Boston in 2006, where unfortunately they lost 6 of 13 patients from fatal radiation pneumonitis, and in retrospect that was because they gave too high a dose to the contralateral lung and did a few other things that we've now been able to avoid in most of the other series. The data from 3 centres have been analysed to look at the major complications, and it turns out that if you're very careful with how much radiation you give to the normal lung, you can avoid most of the side effects. And radiation oncologists will understand this. If we reduce the mean lung dose below 8 Gray, the V5 below 75 Gray, and the V20 below 10%, we can avoid most of these major toxicities. And since 2007, this is what's been introduced in most of the centres who are now using this technique. There is certainly an advantage in using IMRT compared to conventional treatment, which is used in many centres for other types of cancers, we're able to give a higher dose of IMRT to these patients, particularly if they've got the lung intact. We can reduce the dose of radiation that may damage the liver or the other lung, the esophagus, the heart and other organs. And it's been shown that by giving this type of treatment, we can improve local control from 10 to 40% to over 80%. Since we've started on our IMRT technique, this is just a quick review of the 20 patients we've treated since 2006, showing that we've been able to increase the volume that we've included in the hemithorax from 3 gray up to 10 gray in some patients. And we're also now delivering higher doses of 60 gray to a larger volume of the more active area. But it also means that we're also being referred more advanced cases, and instead of rejecting them, we're accepting them if they meet our standard criteria. These are the doses we've been able to give to our patients, and this is the outcome of the patients who've had IMRT since 2006 with patterns of failure. So at the moment, 3 of the 17 patients who've been evaluable have had infill relapses. The other 14 haven't. 7 of the patients indicated by the crosses have died since we started their treatment. This is follow-up, so the patient who had the EPP has survived beyond 3 years with no residual disease or relapse. We've had most of the patients who have recurred have been outside the area we've irradiated. That's the 7 in this colour. We've had 2 patients who've relapsed infield and outfield, but to date there's only been 1 patient who suffered an infill relapse without any other disease. We had 2 patients who are unevaluable, and there's a couple of patients who we haven't done a PET scan on to see how they go. We haven't looked at survival figures. I've got the data, but because our patients have been so advanced, it's probably not relevant to compare them to other series. The other question I'd like to address is the benefit of giving radiotherapy to the intervention site in patients who have surgery to the scars or have biopsies. This has been looked at in the literature, and it's what many centres are doing at the moment without giving good radiotherapy to the disease, which is inside the chest wall. There were 3 studies. They've been looked at in 2 meta-analyses and shown that in general there's no advantage in survival or local progression in giving these low doses to the area just under the skin, and this is why that's the case. I've recently had a patient referred to have our technique who saw another radiation oncologist in another city who had this type of treatment, and what's normally given is a dose of 21 gray and 3 fractions to the area around the scar, which was here, with 12 MeV electrons. Now the problem with electrons is that they don't penetrate very deeply under the skin surface. So here I've been able to reconstruct the dose compared to what we've been adding on to that from the 6-week of treatment, which he finished about a month ago. And if you look at the electron radiation, the 21 gray is given to this area. The area that showed up activity on the subsequent PET scan that he had to plan his IMRT showed that there was a recurrence just inside the rib cage, and this here received a dose of between 1 to 5 gray. So it's not only ineffective, but this particular patient is at high risk of getting skin necrosis because I've given him our standard dose on top of what he had before he saw me, and intervening in the period was he was on a chemotherapy trial which involved immunotherapy, but because he had a sarcomatoid mesothelioma, he recurred, and I felt obliged to give him radiotherapy despite having this contraindication.